Turn it on.
Okay, excuse me, everyone. I want to introduce Dr. Roscoe. Many of you know him. The others that do not know him, this is Dr. Roscoe, our consultant psychiatrist that sees our patients here, and is going to go over managing the dementia patients and the elderly.
Morning. This morning's talk is going to be directed towards the issues of managing the various types of agitation in the demented elderly, particularly in this residential setting, although it would apply elsewhere as well. Memory loss is the core symptom of dementia, but behavioral abnormalities, not the memory loss, are the main reasons for institutionalization. It is aggression, restlessness, and verbal outbursts that often force elderly people into nursing homes, and they are also the most difficult behaviors to manage in the nursing home. It is the management of the symptoms of agitation, aggression, hallucinations, and delusions that are more available at this time. Cognex and Aricept are the only currently available treatments for the memory loss portion of the illness. At some point, most demented patients develop some type of behavioral disturbance. This results in families and other caregivers suffering and struggling with the agitation, misperceptions, and delusions. Behavioral symptoms that have in the past been regarded as reactions to the memory loss are now considered to be an integral part of the disease process itself, with regional specificity in the brain. It is not uncommon to have to try 2 or 3 different medications before one finds an optimal medication that has minimal sedation, minimal Parkinsonian-like effects, and minimal effect on worsening of the confusion and memory loss, while achieving satisfactory control of belligerence and agitation. There is no preferred or proven drug to manage all of these symptoms. The experienced clinician's judgment remains paramount. One expects anxiety to be seen in as many as 30% of patients with Alzheimer's disease. Depressive symptoms in 30 to 40% of patients in Alzheimer's disease. Simple delusions will occur in anywhere from 20 to 60%. This is unlike the complex delusions that occur in schizophrenia. Misidentifications will take place anywhere in reports of 5 to 31%. Hallucinations, 10 to 30%. Of these hallucinations, visual hallucinations are about 15 or 16%, and sometimes you may have noticed they don't even disturb the patient, and so we pretty much would leave them alone. It's when they cause behavioral disturbances, get the patient agitated, anxious, or distressed in various ways, that we have to intervene. Auditory hallucinations will occur in about 10%. Olfactory, gustatory, or tactile hallucinations, much fewer, about 2 to 5%. About 50% of patients with Alzheimer's disease will develop some type of psychotic symptoms during the course of their illness. The majority of Alzheimer's disease patients experience agitation at some time during the course of their illness, and particularly in the later stage. Now, I'd like to go to
Donna Manning, you have a call on
A hallmark of Alzheimer's disease is the loss of insight, which may complicate involvement of patients in their own treatment. Vascular dementia patients frequently maintain insight and may be more able to participate in their treatment. The types of agitation that we expect to be seeing are roughly 20 to 50% will have physically aggressive behavior, such as biting or fighting. Agitated, non-physically aggressive behavior, such as wandering, pacing, or rummaging about, without anxiety, depression, or psychosis. There is wandering per se is not an indication for medication treatment, but simply for redirection by the staff. One also sees restlessness, obstinacy, sundowning, and disrobing. Those behaviors generally will be treated with medications. Verbal aggressions will develop in about 30 to 60% of patients, and that will consist of cursing or screaming. Now, the causes of such behavior are variable. The medical causes would be such things as delirium, infections, pain, claudication, vaginal dryness in women. The psychiatric causes might be depression, psychosis, or anxiety. Environmental causes might be too much or too little stimulation. The risk factors for these agitations are development of more severe cognitive impairments, a lack of social supports, and physical illnesses. Behavioral changes that occur in people with Alzheimer's disease include demanding, irritability, obsessive-compulsive traits with low frustration tolerance. Apathy, withdrawal, disinterest, lack of motivation, depression, tearfulness. Thirdly, hiding things, losing things, and accusations of theft. Packing and unpacking, pacing, searching, moving things about. Hoarding and taking property of other residents. Resistance to bathing and changing of clothing. Wandering, getting lost, worrying, getting agitated. Suspiciousness, delusions of infidelity or of theft. Hallucinations, explosive overreactions, increased restlessness in the afternoons, threats, cursing, sloppiness, tactlessness, hitting, biting, screaming, pinching, kicking, sexual provocativeness, childishness, and silly, regressive types of behavior. All of these aberrations are part of a brain disease. They are not a reaction to the loss of memory. These behaviors change during the course of the disease and even during the same day. The patients have no comprehension of the cause of the behavior or may confabulate a reason. They may not recall their behavior shortly after it has occurred and will look at you with puzzlement and tell you that you're either kidding them or making it up. Reasoning, arguing, coaxing, pleading, or punishing won't change the patient's behavior. Memory loss after the earliest stages of dementia may be relatively less distressing than early on when the person is very aware of what is happening. Patients typically will lose that awareness of their memory loss, but patients do know that they are sad and fearful. That persists. It is the behavioral abnormalities that we have listed that contribute also to elder abuse. Professional caregivers are also more likely to notice and report obvious behaviors such as agitation. Withdrawal and depression, in contrast, tend to be underreported in the nursing home populations. Most disruptive behavior occurs because of fear, frustration, feeling overwhelmed by stimulation, losing the sense of time and place, forgetting what is appropriate, losing control of impulses, physical discomfort, loss of the perceptions of familiarity, inability to understand demands or other types of communication, and the experiencing of frustration. Not all undesirable behavior can be treated with medicine, and side effects of drugs can sometimes create additional problems. Most successful approaches include changes in the caregiver's approach, the environment, or activities. Social activities and day programs can keep patients active at a level that is appropriate for them. Orienting cues, eyeglasses, hearing aids should not be overlooked. Keep a simple environment. An overly complex, too demanding, or too stimulating one can be catastrophic. Reactions may range from withdrawal to agitation. An evaluation of a patient's behavior should include some or all of the following considerations. Side effects of medications that have been prescribed. Always think about depression as a possible cause of behavioral change. Is the person feeling rushed, hungry, tired, scared, or overwhelmed? Does he or she perhaps need to use the bathroom? Are there too many people around, too much confusion or noise? Maybe a change in the environment can be affected. Can you distract, divert, or reassure the person with soothing or familiar activities or objects, or even reorientation in time and place? Is the person cold, hot, sick, over-medicated, in pain, constipated, depressed, or delirious? Consider a medical evaluation if there is an acute change in behavior or confusion. Wandering behavior is not responsive to medication and may simply best be remedied by providing an enclosed area where the patient can walk or pace. Repetitive, purposeless behaviors may be lessened by providing activities, and it is important to prevent daytime napping and enforce a regular sleep schedule without the patient going to bed too early. The adverse effects of certain medications may become manifest in agitated or aggressive behavior. Anti-Parkinsonian agents may cause hallucinations, delusions, mania, and hypersexuality have all been reported. Activating antidepressants and sympathomimetic agents, for example, theophylline, caffeine, steroids, and alcohol, can all cause agitated reactions. Also, Demerol can cause severe agitation. Despite past problems with these agents, the antipsychotics play an important role in the treatment of severe agitated and aggressive behaviors associated with psychosis, delirium, and acute violent behavior. During treatment with antipsychotics, monitoring for toxic effects should be done regularly. The new antipsychotics, risperidone and olanzapine, are very useful in this category because they are less likely to cause Parkinsonian side effects. In conclusion, no matter which therapy is chosen for control of the agitated behavior, careful documentation on the frequencies and course of the behavior is imperative. This leads to identifying specific target behaviors, and it is important in selecting the appropriate therapeutic option. Determine which behaviors are problematic and need treatment. Know which medications are indicated for those problems, and note contraindications for particular drug therapies. Finally, monitoring for outcomes on behaviors and for toxic effects will lead to the best therapeutic choice for the individual patient.
Any questions? Does anybody have any questions for the doctor? Very good. Thank you, Dr.
Just press the red button.
Okay. Okay, ladies and gentlemen. Ladies and gentlemen, this is Charlene Kelly. Our speech therapist has been coming around seeing your patients. You might have seen her on the units. Now you know who she is.
No?
Okay.
I'm in and out during the day about every day about 2 hours, so you may see me, you may not. I'm here to talk about swallowing problems with patients with dementia. It actually dysphagia is what it's called, swallowing difficulties. They affect usually 18 to 22% of all the people that you'll see here in the long-term care facilities, and it's very important because it can lead to aspiration or food going into the lungs if there is a swallowing problem. And this is really important because that leads to pneumonia if it's not taken care of. And of course, we know when a patient gets pneumonia, they are knocked down and weakened all the way around for functioning. Just let me describe dysphagia itself. It's a swallowing problem that is either neurogenic or nerve-based, or it can be even psychological. But for the dementia patient, it's nerve-based. The nerves and the signals being sent to the brain down to the swallowing mechanism are dulled. And it also has a lot to do with the way they feel about the food. They don't want to eat the food. It doesn't taste good. Nothing tastes good but sweet things. And that's just because the taste buds are all dulled. And you'll see that they have problems chewing the solid food. It'll take them... I evaluated a patient yesterday and gave her a piece of chicken, and it took her about 8 minutes to chew one piece of chicken. And you'll see it stuck in the side of their mouths. And the problem there is if it's there and they don't know it's there because the sensation in the face is decreased, they could lay down and choke on that food. So we want to make sure they're on the right diet, and we want to make sure that their mouth is very clear of the food. But I think I'm ahead of myself. The normal swallow that you'll see in a patient when they get the food ready to swallow is 2 seconds, less than 2 seconds actually, and that's for the airway to close and the food to go down into the stomach. If it's taking longer than that, if they're struggling, if they're coughing, if their eyes are watering, any of these things, you know there's a problem. I'll just give you some of the signs to look for. I don't want to be up here all day, and I know you don't want to be here all day. Some of the signs that a patient may be having swallowing problems are eyes watering, difficulty breathing. While they're eating, you'll see the shortness of breath. They may be grimacing when they're swallowing. That may be, there may be some pain. In the dementia patient, a lot of times though, there'll be silent aspirators where they won't cough and they won't have any pain. It'll just kind of go down into the lungs because they don't have that swallow reflex strong enough. You may see them getting really red in the face, and that's it. You'll just see their face turning bright red and maybe their eyes watering, and you'll know that there is a problem there. They may cough right after a swallow or as soon as the food gets in the mouth because the food has a tendency to kind of fall back. And the patients that have that definite posture, you have to be careful when you're feeding them as well. Try to get them, even if it's a hand on the back of the head, a little bit forward, just so they can keep that airway closed off. It's a better situation. Even when they're swallowing drinks, try to get them to tuck their chin. It's not always an easy thing because they don't understand, but maybe if you could just gently push the head forward, it's a lot safer. You'll see them have trouble swallowing meds. The meds will stay in their mouth. You have to, I know all the nursing staff always says, say ah, so I can see if they're down. And if you see that a person is just having the worst time, maybe it's time to crush their meds. It might be, if possible, sometimes you can. They may even complain the food is stuck in my throat. They may have a gurgly voice, like, just filled with gunk. Just have them try to clear their throat and say ah after they drink, because then you'll know that the throat is cleared out and that they're safe. And burping is another thing, that if you see a lot of that, that could be a problem down further, an esophageal problem. So I made a lot of handouts. They're on that background table that'll list all this if you'd like to take some. I may not have made enough, but let me know. I can always make more. Also, you may see them drooling, the food just falling out of their mouth. It's just weakness all around. As I said, pocketing the food in their cheeks, or they may not even be aware there's food being put into their mouth. Some of the things you want to be sure that you're doing with your patients before you feed them, make sure they're sitting straight up. Even when they're in bed, at least get them to 45 degrees. You want the food to have the best chance to get down. And when they're like this, it could sit here, and there's the lungs right there. It could go right in. And also leave them sitting up for at least a half hour if you can after the meal. I know these patients fatigue easily, but try to plan their day so they can be up after the meal. Let's see what else I want to tell you about. I talked about positioning. I talked about problems. Well, some of the ways that we solve these things are an evaluation for swallowing, which I can do. I check for the swallowing delay. I check for the signs of aspiration. I also do some diet changes. Nursing does diet changes. If they see a patient that's chewing on the food, of course they're going to downgrade the diet. We work with dietary and try to get them on the best diet. Also, if you notice a weight loss in a patient that is extreme, you definitely want to look into it, because there is probably something going on, especially if they're eating 100% and there's a weight loss. Then something's up, definitely. Another thing we do when a patient, we're not too sure if they're aspirating, we send them for what's called a video swallow, which they swallow barium, and it's an x-ray of the food going down into the throat, making sure that there's no penetration into the lungs. That is a really, really fantastic test. If I could do it, I'd send every patient of mine to them, because of the swallowing problems that we can't see. There's tons. So I wish I could, but they're very expensive too. So insurance. We can't deal with that. I think that's all I wanted to say. Does anyone have any questions for me?
Do you have anybody on the units that you're having problems feeding? Don't forget, ladies and gents, you are the first line there on the units. They're feeding you the actual hands-on feeding, so you're the first person to see all these symptoms that Charlene is talking about.
Because I'm not here. I mean, the only people that see it are the nurses and you guys.
Well, it doesn't have to be that. It could be any of your residents now that you might have. It doesn't have to be just dementia, some of these things.
It can be a stroke. It can be just old age in general, even if they're cognitively aware. Yes, ma'am.
Sorry.
You in the white now.
We have been notifying the nurse if we've seen any changes with the residents,
Good.
with their eating habits or whatever. And quite a few of the residents want to see them have their diets changed.
That's good.
And I think the problem is before there wasn't somebody here all the time from speech that could do these evals, so now I'm trying to be more available. So just to let you know. I think that's it. Unless you want me to stay longer, I could sing, I could, Okay, so there's handouts up there, and thanks for listening. Good luck.
Is that tall lady to do with you as well? The one that just had a baby? Carla. With the black hair?
Carla, yeah, we work in the same place, yeah.
Thank you, Charlene.
I know what your main interest is, and that's how we can better deal with our residents who have dementia. But I just want to reinforce some of the things that Dr. Roscoe brought up about what dementia is. Everyone has their own idea of a dementia, but remember it's a gradual loss of mental capacity. And with an Alzheimer's, it's a progressive loss, so it can go for a very, very long time. So you might have a resident that has been in this very well alert and orientated. And again, this goes on for a very long period of time. This is the time where usually you're not diagnosed with a disease. I just want to reiterate the importance of having a diagnosis made. There are many medical conditions that can cause a dementia. It could be something as simple as a urinary tract infection. Think about the residents that you've had over the years that have developed high fevers from urinary tract infections, and think about their behavior when they were through this infection time. They're usually quite demented. They're usually very confused, agitated, and that's because of the urinary tract infection. A vitamin B12 deficiency, okay, can cause dementia-like symptoms. So it's very important when your residents or your loved one, someone in your family shows these signs, remember always to have a physical exam and an evaluation done. No one wants to go through life with something on their shoulder that says a dementia. It's a god-awful disease and none of us want to have it. So know that. Bring whatever information you learn through this whole process, bring it home, share it with others, because the better we are educated, the better we can educate people out in the community. Okay, so that's enough on that. I want to talk a little bit about behaviors. I know it's trying to run to the bank, but I just want to, some of the behaviors that you're going to see, this is not only going to be on the new Serenity Place, this is going to be throughout your facility. And I think if we all know how to answer to these people, I think we'll be able, it'll be easier for us in the long run. Our day will be a lot easier. When someone comes to you and says, I'm looking for my mother, I'm going home, I'm looking for my mother, and you can't stop me, and they're hell-bent, they're going to go out that door, what are you going to do? What would be your first reaction? What would you do, Marlene? Mm-hmm.
I wouldn't really try to orient them into, no, you're not going. I would try to work around with them, try to deter them from the area that they're heading, which is the door. Think of something that is probably going to be a lie, but it's going to help them not to go out that door. Find something comfortable, something
Right.
that they like.
Very important. Comfort and something that they like. Meaning, I'm going home to look for my mother. Okay? Remember, a patient with dementia, Alzheimer's specifically, doesn't have a short-term memory, so they don't know what happened, what they had for breakfast, but they will remember what it was like to have their mom 100 years ago, or 50 years ago, whatever. So your best the best answer for a situation such as that is to say, don't tell them, how old are you? Your mother's been dead 50 years. That's only going to increase the agitation. So what I want you to do, and it takes time, to redirect that resident back to a comfortable situation, a quiet area. Again, any of your information that you get through will be quiet, someplace where it's serene, where you can calm them down. Bring them to a quiet area. Redirect them away from the area that they were in, and ask them, what was it like? Tell me about your mom. I know you loved her very much. Tell me about it. Think about something. Reminisce. Go back to the days when things were important to them. Okay? It may take a minute or so, but what a better way to be than with one person asking you wonderful questions about someone you love very much. I guarantee it will work, but it takes time. So redirect them, bring them to a safe environment, and ask them very specific questions. Ask them about that mom, ask them about that dad, ask them about their children. Okay? Don't ever be angry at them for their behavior. They don't know what they're doing. But be firm that you're not going to tolerate bad behavior. So you can tell them, John, you must not do that. That's inappropriate. And redirect them to a different area, but don't yell at them. And that's disgusting. We won't have that here. What's disgusting? He doesn't know what you're talking about. Redirect, find something that interests him, and go on. Can you through their life. Okay? Alzheimer's affects the brain. Remember that. It starts in the brain, but it goes through the whole body and it affects the whole body. And it comes to the end where it affects everything. As we said, they don't know how to swallow anymore. They don't know how to walk to the bathroom anymore. Every little thing that we take for granted is lost to them. So the more that we learn about the disease, and the more that we learn how to deal with their behaviors, it will be much easier for you all. Okay? But remember, it's a progressive disease. Okay? It goes in stages, and your last stage is your death. Okay? There are different types of dementia. Okay? Alzheimer's is a type of dementia. There's a multi-infarct dementia that has to do with little mini strokes to the brain. And again, remember the importance of having a medical eval to rule out some of the physical cause that might be causing dementia-like symptoms. We're looking forward to starting the new unit over in C Building. It's going to be a long process. We're all going to learn from each other. Each resident will have a different behavior. We will know how to deal with that. One person might have an idea. We'll give it a try. You know, it has to be a team effort, and I'm excited about that, and I think everyone else is too. Okay? And keep up the good work. Just remember, if you have a question or you're not sure how to deal with a specific behavior, come to me, and we'll work it out together. Okay? On any unit, it doesn't have to be specifically on the dementia unit. Okay? We learn every day from each other's mistakes. So you might say something right, I might say something wrong, but we'll learn together, and if it works for the residents' benefit, that's what we're here for, to give them a quality life at the end of their life. Okay, any questions?
Yeah, I know you're gonna say this on a time place, but if this is supposed to be a specialized unit, why is it we're gonna have 7 staff?
That's not appropriate for you, we'll discuss that. Okay, we are going to have more programming that's related to a resident that has dementia, and we're working with physical therapy and occupational therapy to get people out of wheelchairs that have been into long carry-in. Dunn, the director of therapy with Greg, has wonderful programs planned. We're working together on a lot of different therapies. Residents will not be in their room. I know you don't believe this right now, but your workload will be very different than what you used to. Your residents will be out of bed, involved in activities, not in their room, doing wonderful things that you're going to want to do with them. And we will evaluate what the staffing is. We have to start from there, and we'll go to another point if we need to increase. Right now, your residents some are in your, really the end of your beginning stages of the disease process. So we still have a lot that we can capture with those residents. You're going to be encouraging your residents to be as independent as possible, and if that means that they pick out a purple blouse to go along with chartreuse pants, we're going to let them do that, because that's what they want to wear, because that's the quality of life we're going to afford the residents. So right now you say 7 is not enough for your 60 residents, but we will try that, and we will maintain their independence. The workload will be very different than what you're used to. Yes?
And also, it's gonna be half off, half of them are mainstream, just regular programs, so it's not like all 60 are gonna be on the unit all day too.
I know from before, with 3 residents who were supposed to be in the rainbow,
Right.
they never left their rooms.
What do you do today, you mean?
No, I'm on about the 3 residents that were in that room down there, and they were supposed to go to the rainbow, whatever it was, the rainbow. They never did get to go.
Yesterday or?
No, this is a while back. This is a while back. I'm about 3 residents who've been moved from this unit to another unit now, but they were supposed to be in a program, and every day they were in their rooms. They never did go to the program.
Yeah, but as Terry had said, we have to start at one starting point and then take it from there. So this is the starting point, we are here. And as we go, it's a continuous evaluation and it's continuous feedback from you ladies, okay? As you're working with the residents where you think you need more help, less help, but where you think you need to feed it into your head nurse, we can feed it into the administration area, okay? But you have to have a starting point, and it's very at this point. And you know, on your other units also, there was a starting point, and then you changed, you increased or what have you. Changes, it's an ongoing process.
anybody, and, you know, you're off for a couple of days and you have that favorite resident, and your first reaction is to go in and give them a kiss and a hug. Watch that when you have a dementia resident. Remember, dementia residents are not very attuned to their surroundings. So if you have someone that's coming up and giving you a big bear hug, that's frightening to them. They feel closed in. So always ask them, is it okay if I give you a hug? They'll let you know if it's not, believe me. And if it's okay, then do it. Okay? Talk to them on a one-to-one. Don't talk to them like they don't understand you, because they do. They may not understand the words that you're saying, but they understand the tone of your voice. They understand the emotion that's in that. Okay? They do. They're just like the rest of us. They love to be loved. Okay? And again, through no fault of their own, they have lost all of their thought processes. So good luck those who are coming to see building, and thanks for your time.
Thank you, Terry.